Hi there, I'm Sarah Train, a junior doctor in Glasgow in the UK, and I'm presenting on behalf of our group from the Geriatrics Department at the University of Edinburgh in the UK. We have no financial interest to disclose. Our study looked at the investigation and treatment of delirium in the first 48 hours after diagnosis. Our aims were firstly to develop a data extraction tool to assess real-world delirium care, and secondly, to examine actions related to delirium management in geriatrics inpatients. As we know, delirium is a common medical emergency, particularly in high-risk populations and those with underlying cognitive disease. Despite this, we found few studies investigating delirium diagnosis and management in day-to-day practice. This is likely due to a number of factors, including that delirium management spans multiple domains, involves extensive investigation for causes, and requires a multidisciplinary approach. In the UK, there are established guidelines for clinical practice, such as the recent SIGN publication and longer-standing NICE guidance. We therefore aim to look at how closely practice followed these recommendations. We developed a novel delirium management report form, piloted this, and then used it to study 30 patients. We performed retrospective case note analysis on 3 geriatric wards of a large city centre teaching hospital, specifically looking at the 48 hours post-delirium diagnosis. All aspects of the guidelines were recorded, from method of diagnosis to recording and correcting physiological parameters, investigating for causes and the treatments of delirium, complications, and communication. We present the most pertinent findings here. Patients had a mean age of 87, a 50-50 gender split, and about half had underlying dementia. We found 67% of patients underwent investigations looking for a cause of their delirium, though the types of investigations ranged. 27% had documented non-pharmacological treatments of delirium started, such as reorientation and one-to-one nursing. Only 2 patients were newly commenced on psychoactive medications. Few cases had documented the impact on the patient, such as assessing for hallucinations and distress. The diagnosis of delirium was recorded to have been communicated to family in 50% and to patients in 10%. Other aspects of care showed similar variability. The limitations of the study include its small sample size and single-centre design. Additionally, the retrospective analysis means informal interventions are missed and therefore could be underreported here. The short study period is far shorter than delirium management likely extends, although we felt the first period from diagnosis was particularly crucial. In conclusion, we found measuring the assessment and treatment of delirium in practice is feasible using a new, novel delirium management report form and could be used to facilitate comparison between units or over time. Once delirium was diagnosed, we found wide variability in the patient's management, notably when assessing thoroughly for causes, specific behavioural and environmental interventions, and communicating, especially with the patients themselves. The low rates of psychotropic medication use are in alignment with the UK guidelines and lower than in similar studies. The impact on the patient, such as assessing for distress, was often not documented, though may have occurred more informally and not recorded. Our study suggests more formal processes for assessing, treating, and documenting newly diagnosed delirium may facilitate more consistent investigation and management. Our references are available below, as are my contact details. Special thanks to my colleagues Drs. Peterson, Marshall and Schenkin, and Professor Alistair McCulloch. Many thanks for listening.